Good afternoon, good evening for some, everybody. It's really a pleasure to come and give another webinar tonight. This one is a very important webinar because it really focuses on a very big part of IVF in women that are running out of eggs, those women with diminished ovarian reserve. We are going to spend 30 to 40 minutes in the presentation itself. This will be followed by a question and answer session, and I urge you to start submitting your questions in the chat box next to the video window at any time of your choice. I would also suggest that if there are any additional questions that don't get answered during this session, that you go to forumshaveababy.com and or to my blog, which is ivfauthority.com, and post your questions there. When you go to forumshaveababy.com, go to the SRM Las Vegas discussion board and post your questions on that site. And obviously, if you go to ivfauthority.com, I will be there within a couple of hours and answer any issues or questions that you might raise. For those of you who might be interested in talking to me directly, please take this number down, 800-780-7437. Again, 800-780-7437. Call and ask Tina if she wouldn't set you up for a Skype consultation with me. And she will do that. There is a bit of a waiting time. I think it's about 6 to 8 weeks before you can get in to see me. But if you ask Tina to put your name down on a short list and someone cancels for whatever reason, she can fit you in quite quickly. So we're going to be talking today about diminished ovarian reserve, which by definition means that the number of eggs left in the ovarian repository, in the woman's ovaries, has fallen below a certain threshold. And from that point onwards, the woman's response to fertility drugs and her overall reproductive hormonal balance is compromised. Now, you all are aware that a woman is born with all the eggs she's ever going to have. And when she goes through puberty and into the menarche and starts menstruating and then ovulating on a monthly basis, even though she usually releases only one egg at a time, in most cases, there are about 15 to 30 or even more eggs used up to get to that one egg that will be used. And those eggs that are used up are forfeited, so that over time the number of eggs left in the ovaries declines. And when it falls below an arbitrary threshold, which can differ from woman to woman, at that point the brain begins to recognize that the ovarian egg population has diminished, and that the woman's marching towards the menopause. In the ensuing 5 to 7 or 8 years, which we refer to as the period of time of premenopause, the woman's ovarian reserve is declining to the point that there's nothing left, and then she goes into the menopause itself. So it's important to understand that this can differ in different women. In most cases, it begins in the late 30s, that the woman's ovarian reserve begins to decline below that threshold. And the menopause occurs anywhere between the ages of 45 and 55 in the United States and in other first world countries. So when we look at trying to measure how many eggs are left in the ovaries, there are only a few ways we can do it. The one is to do blood tests to the woman to measure her FSH level on the 2nd to the 4th day of her period and match that against the blood estrogen level. If the FSH level rises above 9 million international units per milliliter, the woman is moving into that period of the premenopause, and it's during that time that her ability to respond to fertility drugs declines. A more sensitive measure that we use and is almost an all but replaced measurement of FSH as an index of the onset of the climacteric, which is the name used to describe that 5 to 8 year period when ovarian function declines and response to fertility drugs declines, is by measuring the AMH, the anti-Mullerian hormone level in the woman's blood. Using the measure that we use in the United States, measuring in nanograms per milliliter, we know that when the AMH starts to drop below 2 nanograms per milliliter, the woman is moving into the climacteric. And when it drops below 1, she really is there. And when it drops below 0.5, she has very severely depleted ovarian reserve and is very likely to respond well to fertility drugs at all. When that point is reached, there's often very few eggs left in the ovaries. And the woman very often has to start considering the use of an egg donor, or, as we will discuss later on, the option of doing embryo banking. All right. Against all of this background, it is important to remember that when we consider the impact of diminishing ovarian reserve, we must always bear in mind that it's ultimately all about the competency and quality of the embryo that will result when the eggs of the woman are fertilized. Embryo quality and embryo competency, the latter word being the preferable one, refers to the potential of that embryo to propagate a live birth, a healthy baby, if it's transferred into a healthy receptive uterus that is free of anatomical or immunologic implantation dysfunction. So competent embryo is one that has all of its chromosomes intact. And like other cells in the human body, the embryo has 46 chromosomes. And it's only an embryo that has precisely 46 chromosomes that will be competent. But remember, aside from the chromosomes, we're learning more and more that there are probably other factors that also impact on the competency of the embryo. Many of these factors relate to the epigenetic makeup of that embryo and or metabolomic factors. An incompetent embryo is one that has, as I said, got an irregular number of chromosomes where there are more than or less than 46 chromosomes present. Such an embryo is referred to as aneuploid. We can test for aneuploidy of the embryo to see if it's more likely to be competent by doing various pre-implantation genetic sampling tests. We were the first to implement in the clinical setting the use of a test known as CGH, and this we introduced in 2004-2005. CGH allows you to measure all the chromosomes in the embryo, and if the embryo has a full quota, then provided it is placed in a uterus that is receptive, in other words, it's anatomically and immunologically normal, there will be about a 55 to 65% chance that a single competent embryo will propagate a baby. The competent embryo is referred to as euploid, this part of the word, while the incompetent one with irregular chromosomes is aneuploid. So a euploid embryo has exactly 46 chromosomes, while an aneuploid has more or less than 46 chromosomes. An aneuploid embryo will either will stop dividing, or it will not implant, or should it implant in the uterus, it will be brief and usually will miscarry early in the pregnancy. So, in summary, embryo aneuploidy, the irregular percentage of embryos that are got irregular chromosomal component, is the rate-limiting factor in human reproduction. And it all stems, believe it or not, from the egg. It is the egg and not the sperm that sets the pace. Yes, the sperm plays a role, but it is still primarily the egg that will determine whether the embryo is going to be chromosomally normal. Now, here's an important point, and I want you to focus on this for a minute. I want to make it as clear as I can. Roughly 38 to 42 hours before a woman ovulates or before her eggs are extracted with IVF, her eggs usually have 46 chromosomes. In the ensuing 36 to 42 hours, due to the effect of LH, luteinizing hormone produced by the pituitary gland of the woman or present in certain drugs such as Luveris, and also in response to a hormone that acts like LH, namely HCG, the egg is driven into a type of division we refer to as meiosis, and over the ensuing 36 hours to 42 hours after the LH surge or the administration of the HCG, the chromosomes divide down the middle, such that the egg that is ultimately ovulated or extracted, in order to be able to propagate a competent embryo, needs to have exactly half the number of chromosomes it had 36 to 42 hours earlier. This process we refer to as reproductive division or meiosis, and it takes place in that 36 to 42 hour window triggered by LH or HCG. It's then that things go wrong, and they do go wrong. In fact, in humans, the incidence of aneuploid eggs leading to aneuploid embryos, and an aneuploid egg will have more or less than the 23 chromosomes that it would end up with if it divided its chromosomes exactly in half. An aneuploid egg will either propagate will always propagate an aneuploid embryo, and such an aneuploid embryo will either not attach or it will be lost as an early pregnancy loss. In rare circumstances, it will go on and develop into an abnormal baby, such as one with Down syndrome. Now, bear in mind that even in young women, only 1 in 2 eggs that are ovulated or extracted, no matter how good you are at stimulating the woman, or no matter what supplements you take, will be normal, and 1 in 2 will be abnormal. So 1 out of 2 will be euploid with 23 chromosomes. We refer to that as a mature or an M2 egg. And 50% will end up being aneuploid or incompetent, incapable of propagating a competent embryo. As a woman gets older, this likelihood increases, such that by the age of 40, only about 1 in 6 will be euploid, and by the age of 45, probably only 1 in 20 will be euploid, or even less. So age has an inevitable degrading effect through wear and tear on eggs that were in your ovaries ever since you were in your mother's uterus. Age has a tremendously deleterious effect. That is why as women get older into their mid-40s, we recommend that they don't try to use their own eggs, and that they use an egg donor, because the chances of a successful pregnancy diminishes dramatically as the egg gets older. Here is an egg, as you can see it here, that has just been fertilized, and you can see the 2 nuclei inside the egg, one from the sperm and one from the egg itself. This is called a pronucleate or a zygote, because it hasn't divided yet. It's a fertilized but undivided egg. Then this is the embryo when it's divided into 2 cells, and here by the 3rd day, where it usually is 5 to 9 cells in cleavage, this is a cleaved embryo on day 3, and what you see down here is a blastocyst. This is an embryo that's gone from day 3 to day 5 or 6, and gone from 5 to 9 cells to over 100 cells. And the cells arrange themselves around underneath the shell of the egg, the zona, and this is called the troph ectoderm. And then in the middle here you see this inner cell mass, conglomerate of cells that will ultimately produce the baby. It's impossible to tell by looking at a blastocyst which one is competent and which one is not. In fact, in this slide, this embryo, which is hatching, you can see the cells are starting to push out to attach the wall of the uterus. Same as here. They both look beautiful, but this is the normal one, and that's the abnormal one, or the aneuploid and the euploid. There's no way of telling it by looking at the embryo. But as I said, this abnormal embryo will not propagate a viable pregnancy. Now, what is important also is that if an embryo doesn't make it to this expanded blastocyst stage, by day 5 or at the latest day 6, it is almost invariably aneuploid. So who are we kidding? Putting back embryos earlier than day 5 or 6 if they haven't made, putting back embryos that can't make blastocysts by day 5 or 6 is a losing proposition. It is my practice to recommend to virtually all my patients that the embryos be taken to blastocyst so that we can put back those with the best potential to make a baby. Now, we can test the embryos as the blastocyst by sampling some of the cells in the embryo, or on day 3 by removing and sampling one of the cells in the egg. We can basically tell whether all the chromosomes are present by doing PGS testing. The test we use is known as CGH. Another test, which is a newer test, which is proving to be even more reliable, is known as Next Generation Gene Sequencing, or NGS. If we put an embryo into the uterus that is NGS or CGH normal, it should make a baby virtually 55 to 65% of the time, and this reduces slightly as the woman gets into her mid or late 40s. So what then governs the ability of the embryo to be competent? I've already alluded to the fact that the woman's age is a factor. It's a very important factor. But also the woman's ovarian reserve. How many eggs are left in the ovaries? And you'll understand that better in a few moments when I explain that women who are older and women with diminished ovarian reserve have ovaries and eggs that are very vulnerable to the environment in which the eggs develop. And that is why the protocol used for ovarian stimulation, I say it again, the protocol used for ovarian stimulation is the most important decision you can make when you go ahead and treat women who are older or women who have diminished ovarian reserve. And usually, but not always, the two go hand in hand, because as the woman gets older, she gets closer to the climacteric and into the climacteric and becomes premenopausal, where her eggs become vulnerable. And as this happens, usually the age at the same time is compromising the ability of her eggs to develop into normal euploid embryos simply because of age. Now, please try to understand this. Age and ovarian reserve therefore often go hand in hand, but they are independent variables. In other words, if a younger woman has diminished ovarian reserve, she can still produce euploid eggs and embryos and have a baby much more easily than an older woman with the same degree of reduced ovarian reserve, because in the older woman, age has taken its toll on the egg's competency, and thus that egg is more likely to end up making an incompetent embryo. We're going to discuss all of these factors in greater detail. The laboratory, usually blamed by many doctors when embryos are not of good quality, is the least likely to be the cause. Most PhDs in laboratories are very disciplined and will make absolutely sure that they follow protocol, whereas doctors tend to go off on a tangent very often and implement their own idea of what they believe might be better, or in many cases the doctor has read an article and then tries to implement what he or she has read into what they are doing in their practice randomly, and it doesn't work out because not all articles are not always correct. So, the most important determinant of IVF outcome in women with diminished reserve and older women is to select the ideal protocol that will not compromise the environment in which the egg develops. Because if the environment in which the egg is developing before you give the HCG trigger is adverse, then there's a greater likelihood by far that the egg itself will be aneuploid when it is ovulated or extracted. So how do we determine the best protocol for ovarian stimulation? Well, before doing that, I've got to take you to a slide that shows a little section of the ovary. This here is the follicle. This is the egg embedded in the wall of the follicle, and the surrounding tissue around the follicle is known as the stroma or the theca. Now, the stroma produces male hormone predominantly, mainly testosterone, but other androgens or male hormones as well. The testosterone is carried from the stroma to the cells that line the follicle, the so-called granulosa cells, where under the effect of FSH, produced by the pituitary or administered in the form of fertility drugs, converts the testosterone to estradiol, and as it does that, these cells multiply. The granulosa cells start to multiply, and as they multiply, the follicle stretches, and as the follicle stretches, it gets larger. The increased production of estrogen in response to this reaction by the granulosa cells is going to result in increasing levels of estradiol in the blood. And the growing size of the follicle can be reflected in the ultrasound image that we take. Those, of course, are the two parameters we use to measure follicle growth and development. Now, please bear in mind that the egg sitting here embedded in these granulosa cells is also playing a vital role. It is conducting this whole orchestration that allows the FSH to convert the testosterone to estradiol and help the follicle grow and increase the blood production of estradiol, the blood levels of estradiol. The release of testosterone and other male hormones from the stroma is primarily orchestrated by LH, which is the sister hormone of FSH, also produced in the follicle, in the pituitary gland, but also present in certain drugs that we take. And when you give a woman certain types of fertility drugs, you can cause the stroma to overproduce LH. Some of these drugs include letrozole and clomiphene. Now here's the issue. You must have a little bit of testosterone in order to help a follicle grow. If you don't have testosterone production of any concentration, you will not get follicle development. I repeat, there must be some testosterone present for follicle growth to take place. But you don't want there to be too much testosterone. And if there's too much testosterone, it gets into the follicular fluid and compromises the development of the egg over the days that it is present, and this will make that egg be far more likely to become incompetent or aneuploid when you give the HCG trigger because it's been in this adverse environment. Now, you need to bear in mind that there are three groups of women that tend to produce too much LH-like activity. The one is the woman who's older, where her LH undergoes certain biological, biochemical changes that make it more potent. And the second is women who have diminished ovarian reserve, where the brain is causing the pituitary gland to release more FSH and LH in order to try to reawaken ovarian activity. And this translates into increased production of testosterone, getting into the fluid and increasing the risk to that developing egg. Now, when you give fertility drugs, you sometimes give drugs that contain HCG or LH, like Premature. And you want to be very careful how much of this drug you give to older women and women with diminished ovarian reserve, because these are the ones that are vulnerable to producing too much testosterone, which can get into the fluid and damage egg development and increase the incidence of egg and embryo aneuploidy. If you give and supplement a woman with HCG during the stimulation, it will act in the same way as LH and also increase testosterone production. Now, I want to make a very clear distinction here, and this is very important. If a woman is placed on an antagonist, a drug like ganirelix or cetrotide, which blocks the release of LH and FSH from the pituitary, and then is treated with pure FSH, like you find in Follistim, Gonalef, and Puragon, what will happen is that the absence of LH of any LH activity will prevent the stroma from producing enough testosterone, and the follicles won't grow because there has to be, as I said, some testosterone. This has led a lot of people who write and publish on ovarian stimulation to suggest that the addition of testosterone or the addition of LH or the addition of small amounts of LH or the addition of HCG can in fact enhance follicle growth. Yes, it will if there's no testosterone around. There must be some. And as I said, if you cut it off by blocking LH and by using exclusively and only purified FSH, you will starve the developing follicle of testosterone, and you will not get good follicle growth. And in such cases, small amounts of testosterone added can have a benefit. But in most cases, that's not what happens. In most cases, patients receive a combination of Follistim or pure FSH and Menopure in small amounts. And this will be sufficient to cause the stroma, the theca, this connective tissue around the follicle, to produce the male hormone necessary to allow the follicle to process it and grow. So in most cases, adding additional testosterone in that setting or adding additional HCG in that setting is disadvantageous to egg development and should be definitely limited. This is especially true in the two groups of women I mentioned who are much more vulnerable to LH, those who have diminished ovarian reserve and those that are older, in their 40s. Now, as far as I am concerned, the use of other drugs that also increase LH and chronically and thereby increase testosterone should also be withheld in women who have diminished ovarian reserve, and these include drugs like Clomid and drugs like letrozole, because they cause the pituitary to put out a combination of LH and FSH, and the LH will cause an excessive production of testosterone. These drugs are good and okay in younger women with normal ovarian reserve, but in my opinion should be withheld in older women. And when I see so many women going for mini IVF where the doctor uses Clomid or letrozole, I cringe because I don't think this is the right way to go. When you look at the success rate of IVF in that setting, when mini IVF is used with Clomid or letrozole in older women and women with diminished ovarian reserve, you'll see that it's extremely low, very much lower than when you individualize the protocol for stimulation, as I'm going to describe in a few moments. The third type of patient who produces a lot of LH is a woman with polycystic ovarian syndrome. That's a whole different category. We can talk about it at a different time. But women with polycystic ovarian syndrome have an overgrowth of the stroma or theca, and they are extremely vulnerable to LH. And in women with those conditions, there tends to be excessive production of LH, and this increased LH increases testosterone. It gets into the follicles and renders those follicles less likely to propagate healthy eggs and embryos from those eggs. So, again, in the connective tissue surrounding the follicle, LH promotes the production of male hormone androgen, mainly testosterone. Excuse me. And in the follicle, FSH converts the testosterone to estradiol, and the follicle grows. Now, this entire process is orchestrated by the egg as it develops. Again, the egg is the conductor of the entire orchestra. And that is why, if the egg is severely abnormal, follicles don't tend to grow so well. The follicles tend to remain smaller. If in spite of stimulation a follicle remains under 15 millimeters in size, it usually means that the conductor of the orchestra, the egg, cannot do a good job because it's severely aneuploid. And such eggs will not, and that is why we get poor quality eggs out of follicles that tend to be smaller. Okay. And as I mentioned earlier, what increases the exposure to testosterone and androgens? Age, ovarian resistance, which results in the pituitary releasing too much LH and FSH together, and the LH causes increased testosterone production by the stroma, and women with polycystic ovarian syndrome. When women are given inappropriate protocols of stimulation and they fall into the category of being older or having diminished ovarian reserve, this can further exacerbate the production of LH. You see that in flare protocols, where the Lupron given as soon as the cycle begins expunges all of the LH out of the pituitary. It reaches the blood system and the ovaries, and in the ovaries it can compromise follicle growth and egg development if there's too much of it, by the same mechanism I mentioned earlier. Clomiphene and letrozole cause a chronic release of LH, which has the same effect. And minotropins such as Lupron, which contain LH and HCG activity equal to the amount of FSH activity, must be used sparingly in women who fall into this category here. Another thing that causes increased testosterone production in the ovary that can compromise follicles is the presence of tumors or lesions in the ovaries, endometriomas, chocolate cysts, functional cysts, or tumors in the ovary will aggravate and activate the surrounding connective tissue or stroma, and increased testosterone will be produced. And this, in turn, will compromise the eggs in the ovary that is so affected. And then the over-administration of testosterone can do the same thing. Now, DHEA, which we read so much about and is being touted by so many as a miracle supplement, is fine in a younger woman with normal ovarian reserve. But if you start giving DHEA to women, by the way, I don't think it helps at all in any case. But if you use it in women who have diminished ovarian reserve who are older, it gets converted to testosterone in the ovary, gets into the follicular fluid, and in my opinion can compromise egg development and increase the risk of egg and embryo aneuploidy and incompetency. So how do we limit the exposure to testosterone? Obviously, firstly, limit the exposure to LH in the drugs you use to stimulate the woman. Use purified FSH like Follistim, Gonalef, or Puragon. Second, if there are any ovarian lesions before you begin the stimulation, like endometriomas, cysts, or tumors, remove them. Treat them before you go into the cycle of stimulation in order to allow the ovary in which they reside to have a better chance of developing eggs that will be competent. Then suppress the release of LH during the protocol of stimulation. avoid using drugs like Clomid and Femara, and avoid flare protocols, especially in older women and women with PCOS, and use the typical long pituitary protocol, be it with agonist alone or agonist-antagonist protocols. This is especially helpful in women with diminished reserve and women that are older and women with PCOS. So let's talk about these protocols. What is a long pituitary downregulation protocol? Well, we put the woman on a birth control pill for at least 10 days. And while she's on the pill, we overlap her with an agonist, Lupron, which works by expunging all the LH out of the pituitary. And by continuing to administer the Lupron all the way through the stimulation, starting 3 or 4 days before the period arrives, we are able to keep the LH at a low level. That which is being expunged is quickly removed from the system, from the body. So 3 or 4 days before the period comes, we overlap the birth control pill with Lupron or buserelin, and wait for the period. The period will come within about 5 days, and then we start giving low dosage in the regular situation or higher dosage when it comes to diminished ovarian reserve, FSH recombinant such as Follicle, Gonal-F predominantly, and add a small amount of Menopur or Luveris, which contains LH-HCG-like activity, which must be present. Some of it needs to be there to enable the actual conversion of the testosterone to estrogen and the development of the egg in the process. And all this continues until the period begins, and then we trigger the woman with something that will send the eggs into meiosis over the ensuing 36 to 42 hours. I use exclusively HCG, the regular HCG, Novarel, Profasi, or Pregnile. But you can use recombinant HCG in the form of Ovidrel, provided that you give 500 micrograms and not 250. 250 is equivalent to about 6,000 units of HCG, not the optimal dosage. So double the dose to 500 micrograms. Because the Ovidrel comes in vials of 250 micrograms, many doctors still use only 250 micrograms. And when you do that, there's just not enough push to send the eggs into proper reproductive division or meiosis, and you end up with a higher, in my opinion, risk of aneuploidy of the egg and therefore the embryo. Now then there's the agonist-antagonist conversion protocol, which is a modification of the long protocol that we introduced some 15 years ago. It's an excellent protocol, especially for women with diminished ovarian reserve. Here the woman is again on a birth control pill for 10 days, and again she overlaps the birth control pill with a Lupron, and then within 5 to 10 days she has a period. At this point, the Lupron, the agonist, is discontinued and supplanted with an antagonist, ganirelix, or cetrotide, or orgalutron. They're all the same. And this is given daily in combination with the recombinant FSH and the Menopur Luveris that I spoke about earlier. It's important to know that the dosage of this drug that you use is very much influenced by the degree of ovarian reserve. We don't have the time to go into that. That's a medical decision on how much to give. But the greater the diminished ovarian reserve, the higher the dose of FSH. You always use a low dose of Menopur Luveris, in my opinion, never more than 75 units a day. And then you stimulate until the trigger with HCG, and then all with Ovidrel 500 micrograms, and 36 hours later you go in and you extract the eggs under conscious sedation and ultrasound guidance. This merely explains what I mean by the flare protocol, which I never use, and especially not, in my opinion, in women who've got diminished ovarian reserve. Here, the agonist is started at the onset of a spontaneous menstruation. And you give the agonist, and then you, at the same time, or within a day or two of starting it, add the FSH and Menopure, and stimulate to the point of HCG. The use of flare protocols was at first thought to be of great advantage in women with diminished reserve. It was almost regarded like having a springboard effect. If you give the agonist, the pituitary gland releases more FSH along with the LH. And this was thought to boost the effect of the FSH being administered in the form of Follicle or Gonal-F, and as such was touted as being a way to preferentially stimulate women with diminished ovarian reserve. In my opinion, this is a big mistake. I don't think this protocol should ever be used in older women or women with diminished ovarian reserve, because the expunging of all of the LH out of the pituitary gland along with FSH will reach the ovaries and increase male hormone production, with all the risks I mentioned earlier. Then there's a short antagonist protocol that we all know and most of you have used, I'm sure. This is where the woman starts a period, and then when she's had stimulation with her Follicle, Gonal-F and Menopure for about 6 to 8 days, the antagonist ganirelix is added on the top of it. The reason this is done is to try to prevent what is often referred to as a premature LH surge. That means the LH suddenly rises, and this causes a premature luteinization, too much release of testosterone, egg quality is compromised, and those eggs don't make babies. And we diagnose that when a woman who's been stimulated suddenly sees her estrogen levels drop by more than 20% in a period of 24 hours, and along with it the LH level starts to climb. But contrary to what is commonly called a premature surge in LH, this is by no means a surge. In these women, what you'll see is the LH level starts to go up in a staircase fashion, reaches a certain point, and then it takes off. By the time it takes off, the damage has been done by overproduction of the woman's own LH in the natural cycle. And at this point, the eggs are doomed anyway. I believe I don't use this short antagonist protocol on my patients. I use the agonist-antagonist approach. I don't use the short antagonist protocol at all. I will say this: if you're going to use a short antagonist protocol, or even if you use the flare protocol, which I don't think is a good thing to do, in my opinion, this should never be done
just about 30 seconds ago.
Okay, let me go back. I suddenly lost sound here. So the first thing is that when you use the short antagonist protocol, or you use the flare protocol, which I don't use, you should, in my opinion, never give it coming off a birth control pill. Because the birth control pill will suppress FSH. And you need a little rise in your FSH before the cycle begins to get the little antral follicles, those 4 to 6 millimeter follicles that are lined up in the ovary and are going to be responding to fertility drugs. You need that rise in FSH for them to form. If you don't have that rise in FSH, then the little antral follicles cannot respond to FSH that you stimulate with. and you take much longer to stimulate, there's a discordance in follicle growth, and you end up with poorer quality eggs, in my opinion. And for this reason, whenever this short antagonist protocol is used, or when a woman goes on even a flare protocol, it should be coming off a natural cycle and not coming off a birth control pill, which suppresses FSH completely. Mini IVF is something that I decry because I don't think it has a place in IVF in general, and certainly not when it comes to older women. And the reason is that older women and women with diminished ovarian reserve already have increased LH activity. With mini IVF, the use of clomiphene or Femara to stimulate the cycle in the hope of reducing the amount of FSH that you need to give subsequently deludes you, because what really happens is you're increasing LH even further. And these are the women that end up, in my opinion, with poor quality eggs. The use of mini IVF in older women or women with diminished ovarian reserve is, in my opinion, associated with much lower success rates. Normally what happens is you get about 5 days of Clomid or clomiphene or Femara, and then to this is added Follistim or Gonalef with Menopure in some cases. It's this combination which allows you to use a lower dose of stimulation to get the same effect. But in this case, using a lower dose doesn't advantage the patient at all and can compromise the eggs, in my opinion. Natural cycle IVF, I'm not going to go into here. It's got the same problem, because women who have diminished reserve and who are older will have increased LH. And if you do nothing to reduce that LH, you're doing nothing to protect the eggs during stimulation. And then there's the one that we use in the ultimate situation where the woman has virtually depleted ovarian reserve. Her AMH is 0.1, 0.2, 0.3. It is so low. In such cases, we developed the agonist-antagonist conversion protocol. Dr. Geoffrey Sher and I published on this about a decade ago. Here what we're doing is we're giving the woman the birth control pill again for 10 days, and we're again overlapping with the Lupron, the agonist, to cause FSH to be released that'll get the antral follicles ready to respond. But as soon as the period begins, we then start the antagonist. We switch from the agonist to the antagonist, giving at the same time estrogen in the form of injectable estrogen, estradiol valerate. Del-estrogen is its commercial name. And we give that by injection twice a week to allow for even absorption. It's given for a full 7 to 10 days. And then after you've given the estrogen for 7 to 10 days, you now add the Follistim and the Menopure. The 7 to 10 day period on estrogen before you start the stimulation primes the receptors on the cells in the follicle, on the granulosa cells, tending to make the follicle more responsive to the stimulation with FSH and Menopure that follows. You continue the estrogen, the estrogen priming effect with the del-estrogen, and you stimulate. And when the follicles reach about 12 to 14 millimeters in size, you can stop the estrogen and just continue with the FSH and Menopure. This is called the agonist-antagonist conversion protocol, or the estrogen priming protocol. It works well in some women who've got severely diminished ovarian reserve, and then you trigger with HCG, or 10,000 units of HCG, or 500 micrograms of Ovidrel. So who benefits from this? As I stated, this is for women with very severely diminished ovarian reserve. Using this agonist-antagonist conversion protocol can sometimes result in the stimulation cycle being prolonged by 4 to 7 days, but that's not necessarily disadvantageous to egg quality. Now, I've mentioned the issue of using HCG versus Ovidrel. I'm not going to go into it again, but the criterion I use is that the trigger is done when at least 2 follicles are 18 to 22 millimeters, with half of the rest being over 15 millimeters. What about supplements that might increase response to stimulation? Well, there's human growth hormone. Whether it works or not, the case is still out on that. I do use it. There are various protocols we give. It is thought to increase the action of the mitochondria, the energy generating units within the cell that signal the DNA in the egg to respond better and develop better. So human growth hormone is often added in women with severely diminished ovarian reserve. You can ignore GSF. Antioxidants and vitamins, mainly coenzyme Q10 and folic acid, may have some advantage. And then there is DHEA, which I've already decried in women who have diminished reserve. A few additional considerations to bear in mind. Women who have diminished ovarian reserve are much more susceptible to the so-called premature LH surge that I mentioned earlier, or premature luteinization, because they already have high LH levels, and this is rising progressively. Unless you control it to keep the LH level low, you're going to have to deal with this premature luteinization, which really damages eggs badly. The second consideration is something called the empty follicle syndrome. We often see in women, especially those with diminished ovarian reserve or those who have high LH exposure, that egg follicles don't yield eggs. You get the fluid out, but the egg doesn't come out, and the doctor says, oh, those follicles were empty. Well, believe me when I tell you there's no such thing as an empty follicle. You can't have a follicle without an egg orchestrating its growth. So whenever you hear there's no egg that came out of the follicle and you're told that it was an empty follicle, say to yourself, that meant that the egg in that follicle was so badly abnormal chromosomally that it couldn't signal the dispersion of the cells surrounding it to loosen up to allow it to come out when you hit the pedal and try to suck the egg out. Empty follicle syndrome is an indication of poor stimulation. Doesn't mean that it was deliberate. Doesn't mean it was intentional, obviously, but it definitely means that something needs to be done to alter the environment in which the follicles develop next time round. And the final point I want to make is a very, very, very important one. It now comprises virtually a third of my practice. I see women from all over the world who come to me with diminished ovarian reserve in the hope that we can do something miraculous to try to improve the egg quality. And we can't. All we can do is, going back to what I said initially, the most important factor is to choose a very individualized and strategic approach to ovarian stimulation that is tethered to the needs of the individual. Embryo banking is a way in which we can build up the number of embryos before we test them chromosomally and decide which ones are worthy to transfer. And it has a very specific place in women who are older and women with diminished ovarian reserve, or a combination of both. If they don't want to do egg donation, or if they don't need egg donation yet. Here we stimulate the woman, we extract her eggs, we fertilize the eggs by ICSI, because we do 100% ICSI in our practices. We allow the eggs to divide to day 3, and we biopsy the embryos for NGS, next generation gene sequencing. But we don't send away the biopsy materials immediately for testing. We freeze the DNA we biopsied. And then we let the woman go home. We wait 1 month to rest the ovaries. We come back and do it again, and keep on doing it till we've been able to bank at least somewhere in the vicinity of 6 to 8 blastocysts over time. Then, having all the biopsies from all the embryos that we've biopsied along the way, we send them all away once for NGS testing, and so we reduce the cost of the PGS testing, of the genetic testing. Once we know which embryos are normal, we hold on to those and preferentially replace those into the uterus that turn out to be the normal ones. Again, we put back no more than 2 at a time, and often 1 at a time, with a much higher chance of success because we've now been able to identify the embryos that are most likely the ones that have the best potential to propagate a baby. I'm not suggesting for a minute that the chromosomal makeup alone, as I said earlier, determines whether the embryo will make it. There are other factors as well, but that is the main factor that plays a role. Embryo banking is an option, an alternative for women who have diminished ovarian reserve, and especially those that are under the age of 43 years. The older women with diminished ovarian reserve really should do egg donation as being the only realistic choice. And women who've got depleted ovarian reserve, very severely diminished ovarian reserve of under 0.3 nanograms per milliliter, those women are probably also advised, regardless of age, to seriously consider egg donation preferentially. Embryo banking allows you to literally stop the biological clock in the right patient. It's not for everyone, but for those who want a chance at using their own eggs but are running out of time with their own eggs because of age or diminished ovarian reserve, embryo banking does offer a solution. And again, if you want to know more about it, I urge those of you interested to contact Tina at 1-800-780-7437 and to ask her to set up a Skype consultation with me so we can discuss your case in greater detail. Again, 1-800-780-7437, and or go to my blog, ivfauthority.com, and when you get to the search bar on the home page, then I suggest what you do is you go to the search bar, type in to that search bar embryo banking, click on it, and it'll take you to an article to articles that I've written there on this particular topic. Thank you very much for your attention. It's a complex issue. I hope this was helpful to you. And now I'll take questions and try to go through them as quickly as I can. Where do we start? Okay, here's one from Bo who says, I'm 41, FSH is 7, AMH is 0.9. I had one IVF cycle which resulted in a pregnancy but miscarried due to trisomy 13, which is aneuploidy. Do you recommend a fresh transfer for someone like me on day 3 or 5? I do not. I think you are an ideal candidate for embryo banking that I've just described in some detail. I urge you to give me a call because I think that will probably be your best chance. Dial 800-780-7437 and ask Tina to set that up for you. I'd be looking forward to talking to you. Kimberly says, for a woman of 45 with antral follicle count of 5, what are the chances of success? With mini IVF, Kimberly, I've told you that the chances with mini IVF, even in young women, is negligible. My recommendation is that you don't do it. The chance of success is going to be well under 5%. Am I okay? Okay, the next one is Heather, who says, does obesity affect ovarian reserve count? Can it affect the level you are reading? I really don't think so, Heather. Being overweight adds other problems hormonally and also adds the technical difficulty of IVF and of pregnancy. But it should not affect your ovarian reserve. Brooke says, I've had 2 IVFs, 5 large follicles with only 1 embryo rested on day 4 and 1 large follicle and 1 premature egg. Plan on doing another IVF. What should you do in this case? Brooke, it would be helpful to know your age, but with diminished ovarian reserve, I would urge you to seriously give consideration to embryo banking before you run out of time. I have a patient right now that went through IVF 6 months ago and had an AMH level that was normal. or just slightly below normal. 6 months thereafter, she comes to me, and her AMH is 0.4. It can drop that fast. And imagine it can drop, if you're already at a 0.5 or 0.6, it can drop to the floor within a matter of months. So you need to make hay while the sun shines, Brooke, and give me a call at 800-780-7437. Ma'am says, I'm 36 with endometriosis, which was removed in 2015. I did IVF in May, which resulted in 6 embryos, but all arrested by day 5. Ma'am, this is more than likely an issue of the protocol used for ovarian stimulation. You probably need an agonist-antagonist conversion protocol, ideally, maybe with human growth hormone supplementation. Give us a call and we can discuss it. Brooke writes, I've had 2 IVFs, 5 large follicles with only 1 egg embryo. I think we answered this one earlier. It's the same here. Stephanie says, why or how does AMH change? You said in October of 2014, it was 5.1. It was 0.51. March was 1.49 and July was 0.65. You're 33 with an FSH of 8.9. Well, one thing's probably pretty clear. Your ovarian reserve is diminishing, and diminishing prematurely, Stephanie. So you need to be talking about the protocol used for ovarian stimulation. This is by far the most important consideration for you and other women like you. The next one is June, who writes, my FSH is 7, but my AMH is 1.02 at age 35. Many eggs retrieved in the past, 5 IVF cycles, but only 1 of them went to blastocysts. This, in your case, with an AMH of 1.02, your ovarian reserve is starting to get to the point where it's going to cause problems. With it being above 1, you're still okay. But truthfully, you need to start thinking about proactivity. You should be looking at possibly considering testing and doing embryo banking. What is the difference between CGH and PGD, PGS? CGH is simply a form of PGS, PGD. It tests, all the methods of testing will differ, but all of them aim at assessing the chromosomal integrity of the embryo. Stephanie writes, what makes a good candidate for mini-stim IVF? If you want to know the honest truth, Stephanie, everything in a mini IVF cycle is similar to what you do in a regular IVF cycle, only you don't take as much drugs and the cost for the drugs is lower. But the monitoring and the evaluation and the egg retrieval and the transfer are all the same. That's why I don't use mini IVF. But if anybody is a candidate for mini IVF, it would be a younger woman below 35 years of age who has normal ovarian reserve and who's not as susceptible or vulnerable to the increased LH production that occurs when you use Clomid or letrozole. Kimberly writes, what is your opinion of using DHEA? I've already alluded to the fact that I do not recommend the use of DHEA because it converts to testosterone. If you're going to use it, then it should be used in women who don't have diminished ovarian reserve. In my opinion, it is potentially harmful for older women and women with diminished ovarian reserve. Barbara writes, I'm 34 years of age, just did fresh IVF at 7 eggs retrieved, all fertilized. 6 made it to blastocysts. 2 were transferred and 4 frozen, but negative betas. What are the chances of the remaining 4 frozen ones working? Well, Barbara, it all depends on whether you have an implantation problem or not, and whether the embryos being transferred are normal. Now, at 34 years of age, 1 out of every 2 blastocysts should be normal, so transferring 2 blastocysts to a receptive uterus should give you a 50-50 chance of a pregnancy, or roughly so. In my opinion, therefore, since you can't do anything about the embryos that are frozen, and thawing them in order to retest them, then refreeze them so you can get the results, only to rethaw them to transfer them is too stressful on the embryos. So in my opinion, you need to be tested for an implantation problem. First, is the lining thick enough? Over 8 millimeters and preferably over 9 on the day you get the trigger shot or the progesterone starts. 2, can you exclude a surface lesion such as polyps or scarring in the uterine cavity? And 3, can you exclude an immunologic implantation problem linked to activation of uterine natural killer cells? Those things need to be evaluated before you go to the next 4 blastocysts and lose them unnecessarily. Give us a call. I'll be happy to discuss that with you. The next one says, if a donor... Is that the right one? I think that it jumped up. Yeah. Is it possible for AMH to go from less than 0.1 to 0.5 and FSH from 17 to 14? Thought they only went one direction. No, they don't. There are other factors that can also influence the levels you measure. But the general trend is that FSH keeps getting worse, and you always look at the highest FSH and the lowest AMH as an indicator of your real ovarian reserve. Now comes Laurie. He says, now comes, you say, if a donor suffers a little bit of ovarian hyperstimulation syndrome, will that affect the quality of the eggs? It can, especially if the doctor gets nervous that you might develop severe ovarian hyperstimulation syndrome and triggers you with HCG before the eggs are fully developed. That is a whole different story and a whole different topic. Bo says, what do you think about using low-dose HCG instead of Menopure? It's not necessary if you use the protocol that I've recommended, namely using low-dose Menopure combined with Follistim. But if you are using pure Follistim or pure Puragon or pure Gonal-F and you want to add a little bit of HCG rather than giving the Menopure, you can do so. But it's got to be very, very little, and you've got to be very careful in women who've got diminished reserve. Anna writes, I'm 25 and I have high levels of natural killer cells. And Dr. Saleh said that the natural killer cells are affecting my eggs and I have low egg reserve. I respectfully, because I admire Dr. Saleh so much, he's an outstanding RE. But he and I really differ here. I don't believe natural killer cells have got any link whatsoever to the quality of eggs. And again, let me reiterate, if my daughter needed IVF, I'd gladly send her to Dr. Saleh. I think he's an outstanding RE. But at the same time, I totally differ with that opinion that if that's what he expressed to you, he and I would differ strongly on that. Anna writes, part 2 of my question also, how much time do I have to save? Do I have to save for IVF? At 25, boy, oh boy, at 25, you've still got plenty, you've got very good quality eggs linked to age. It all depends on your ovarian reserve. I think you've got plenty time, Anna. I would love to know what your AMH level is, because that would help me answer more authoritatively. June says, what do experts find that causes diminished ovarian reserve in age 29 to 35? Can regular heavy exercise like cycling, running, or dancing, or stressful? No. I doubt that the latter are going to be issues. But there are conditions such as Fragile X syndrome, which is a genetic disorder, a chromosomal disorder. There are conditions that are mainly genetically linked that will cause certain women to go into premature ovarian failure. There are chromosomal aneuploidies, such as Turner syndrome, where the woman's only born with a single X rather than 2 X chromosomes that are associated with premature menopause or primary ovarian failure. And then there is diseases in the pelvis that destroy the blood supply to the ovary. By cutting off its blood supply, the eggs die off earlier. Or it can happen after surgery has damaged the blood supply to the ovary, or of course in cases where the ovaries have been removed. It can also happen in women who have been placed on chemotherapy or have undergone radiation therapy for cancer of the ovaries or cancer in the pelvis, and the ovaries get exposed to radiation. Kimberly writes, would you consider a 45-year-old with antral follicle count of 5 severely diminished? Yes, I would, but bigger than the low antral follicle count, I would be concerned about 45 years of age and the impact that that has simply because of age on egg quality, where only 1 out of 20 or 25 eggs are going to be normal. Another one, how well do embryos thaw? If embryos have been frozen by vitrification, which is the ultra-rapid freezing method, they should not be damaged, and 90% of them should survive the freeze-thaw. Tamika writes, I'm 40 years of age and had my first child in June. Congratulations, Tamika. How long should I wait to try to conceive again? Tamika, I would wait till you've finished breastfeeding and have allowed 1 or 2 regular cycles to occur after the breastfeeding is done. And that's when I'd say you'd probably be ready. Molly says, I'm 34 and my AMH went from 1.2 to 0.3 in the last 8 months. Fertility doc wants to do testosterone injections because my testosterone is less than 20. Do you think estrogen priming would be better? I don't know if you need estrogen priming, but I would definitely use an agonist-antagonist conversion protocol, and I would not use testosterone injections. Judith writes, I had 13 eggs retrieved for egg freezing. I'm 38. What are the chances that do I have for a successful pregnancy? That's a whole different story, Judith. When you freeze eggs, each egg that you freeze going in, before you know if it survived the freeze, whether it thawed and survived, whether it makes embryos, before you know any of that stuff, every egg you freeze has at best a 7% chance to make a baby. And the reason is you don't know which eggs are chromosomally normal. And the only way to do that is to biopsy the eggs and do PGS testing of the eggs before you freeze them. And if you know that, then, and you have 13 eggs that are normal, then your chances of having a baby from those eggs, if they had been tested, would be excellent. Now with 13 eggs, I figure the chances are probably in the order of about 30 to 40%. Judith writes, the estrogen level was 98.4, FSH 8.27, LH level 3.9, and I don't know your AMH, but I will tell you this, that if the estradiol level is over 70, then you're under-reading the FSH. So an 8.27 is probably north of that, higher, indicating that you do likely have diminished ovarian reserve. You should have your AMH tested to be sure, and give me a call. Time is an issue for you very clearly. The number is 800-780-7437. Try to set up a Skype consultation and we can talk. Judith writes again, after 10 days of birth control before starting the cycle with 5 units of Lupron with the Follistim and Menopure. Now I don't understand. Are you saying that your FSH was 8.7 after 10 days of birth control pill before starting the cycle with 5 units of Lupron? The answer remains the same. Bo says there's a school of thought that says freezing is too stressful on older eggs. Thoughts? Do you think for older women the uterus is a better place and earlier transfers preferred? Bo, that's absolute nonsense. You mean embryos derived from older eggs? And the answer is still nonsense. The answer is that if the embryo is healthy, if it's chromosomally normal, and those are the only ones that can make babies, whether it comes from an older woman or a younger woman, it's best allowing the embryos to go to blastocysts, because those that don't make it are not going to make babies anyway, almost ever. Do you treat women of age 45 with IVF using their own eggs? Kimberly, it's not my job to tell people what to do. I can only recommend what I think is advisable. Ultimately, my job is to provide information so the patient can make the ultimate choice. I would treat, but with great reluctance, and not until I'd had a conversation with you to try to tell you why I think egg donation should be considered preferentially. But for single women, even at 45, using an egg donor isn't a good option sometimes, because they have to use a sperm donor as well, and there's no familial connection to the baby. In such women, I would be more willing to consider, more open to considering using own eggs. Although again, I repeat, after 43, the preference should be to use donor eggs. Anna writes, I don't know any of my levels. All Dr. Saleh told me was that I am in the yellow. I'm nervous because I think IVF won't work due to being in the yellow reserve. Anna, you may have diminished reserve, but I need to see those numbers myself. All I can tell you is that in my opinion, it's got nothing to do with your natural killer cells. Constanza writes, what is an appropriate dosage of CoQ10? 600 milligrams a day is a good dose. How many average banking cycles do you think diminished ovarian reserve woman needs? As many as it takes to accumulate and bank enough blastocysts that will provide at least 2 or 3 that are chromosomally normal for transfer. But if, of course, in the first and second cycle, you get no blastocysts and you don't get enough mature eggs, then it's often the time to stop and to move on to egg donation. Cindy says, AMH is 6.7, FSH 5.3. That's excellent reserve, Cindy. You don't have a problem. Is that the last one? All right, guys, I see all of you have stuck around, and that makes me feel very good, because it means that some of what I've said may have been of value to some of you. I do this on a regular basis every 6 weeks with my batches of cycles, because I do my IVF cycles in batches. And when I do a batch of 2 weeks, I like to do a webinar. I really enjoy it. I enjoy interacting. And I thank every single one of you for taking the time to come to the webinar and listen. I urge you to go out there on the social media and let people know that these webinars are being held. Each one of these webinars is archived for future reading on our website, haveababy.com. So I urge you to get the word out there, and I tell you again, I really appreciate you. I thank you very, very much for your interest. There'll be other questions that we haven't gotten to, and so all I can ask you to do is to post those questions on ivfauthority.com. Go to www.ivfauthority.com and find the place where you post the questions or issues, and I promise to get to them quickly and answer them. And once again, thank you, every one of you, for your time, and I hope this was really helpful to you. Have a wonderful evening.